All right, welcome back to the deep dive. And just looking at the stack of books on the desk here, I can feel my blood pressure starting to climb.
I can imagine.
This isn't one of our usual browses, is it?
Yeah.
We are deep in the trenches today. We're in full-on exam prep mode.
Full exam prep mode. And not just any exam. We're simulating that pressure cooker that is the MD anesthesiology postgraduate exam.
Right.
Specifically, we're targeting those rigorous standards, the ones expected by examiners at places like Gujarat University. We're aiming for that big one, that 20-mark long answer.
The topic on the table is diuretics. It sounds deceptively simple. You think, okay, water pills, Lasix makes you pee. But if I just write that on my exam paper, I'm going to fail, aren't I?
Oh, you will fail spectacularly. And you will probably get a very, very stern look from the external examiner during the viva voce.
I'd like to avoid that.
They don't want a shopping list of drugs. They want physiology. They want precise pharmacology. And most importantly for us, they want the anesthetic implications. They need to know you can handle these drugs safely in the OR and the ICU.
Okay, so I'm playing the role of the eager PG student today. I've got my K.D. Tripathi for pharmacology, Guyton for physiology, and of course Miller for the anesthesia side of things. You are the senior faculty. So walk me through this. How do we build the perfect answer?
We are going to dismantle this topic with surgical precision. We'll follow the classic long answer structure. First, the basic concepts, then classification. After that, the individual classes of drugs, and we finish with the big one, clinical and anesthetic implications.
Oh, raid map. I like that.
If you stick to this roadmap, you cannot get lost. It keeps you organized and ensures you hit every key point the examiner is looking for.
Okay, let's start with part A. Basic concepts. The introduction. If I'm writing that first paragraph, that first impression, how do I frame the definition?
Start with the simple textbook definition, but then immediately pivot to the mechanism. So you start with, a diuretic is any substance that increases the rate of urine volume output. Simple.
Okay.
But then you add the crucial sentence. However, most clinically useful diuretics exert their effect by decreasing the rate of sodium reabsorption. This process is called natriuresis.
Because water follows sodium.
Exactly. It's a fundamental principle. Sodium is the driver, water is the passenger. So technically, we're causing a primary natriuresis, which then leads to a secondary diuresis.
That's a great distinction. It shows you understand the underlying physiology, not just the outcome.
That's what gets you the marks. It shows you're thinking about ions, not just water.
Why is this a must-know topic for an anesthesiologist? I mean, beyond just knowing the drugs.
Because we are the masters of fluid balance, or at least we're supposed to be. We use these drugs constantly to manage edema, in heart failure, in liver disease, in renal failure. We use them to treat hypertension.
And in our world specifically.
In neuroanesthesia, we use them to shrink the brain. In the ICU, we use them to manage fluid overload. But, and this is the key point to make, they are double-edged swords.
How so?
They profoundly affect our hemodynamics, they alter preload, they cause massive electrolyte shifts, and they can completely change how our other anesthetic drugs, like muscle relaxants, work. So you have to respect them.
Right. So I've defined it, I've stated the importance. Now, before I even list a single drug, I need to talk about the battlefield, don't I? The kidney itself.
This is very high yield. Underline that in your notes. You cannot explain how these drugs work if you don't first explain the nephron. You need to sketch out the renal physiology relevant to diuretics. Think of the nephron as a sequential reabsorption line.
Okay, an assembly line in reverse. Let's walk down that line. We start at the proximal tubule, right?
The proximal convoluted tubule, or PT. This is the absolute workhorse of the kidney. It reabsorbs about 65% of all the sodium and water that gets filtered.
65%. That's a huge amount.
It's massive. It has a huge surface area, a brush border, lots of mitochondria. It's built for bulk transport, and it's highly permeable to water.
Now, here's a question that always trips me up. If the PT reabsorbs 65% of the sodium, why aren't the diuretics that work there, like Acetazolamide, the most powerful ones we have? It seems logical that blocking the biggest worker would have the biggest effect.
And that is a classic Viva trap, an absolute classic. The examiner is baiting you with that question.
So what's the safe answer?
The answer is 2 words: distal compensation. The nephron has a huge reserve capacity. If you block reabsorption at the start of the line, in the PT, the downstream segments, specifically the loop of Henle and the distal tubule, they sense that extra load of sodium coming their way.
And they just work harder.
They work much harder to reabsorb it. They upregulate their transport mechanisms. So even though you've knocked out the main workhorse, the rest of the team picks up the slack. The net effect is surprisingly small. That's why PT diuretics are generally classified as weak.
That makes perfect sense. High capacity upstream, but also high compensation downstream. Okay, let's move down the line to the loop of Henle.
This is the engine room. This is where the kidney creates its ability to concentrate urine. Specifically, we're talking about the thick ascending limb of the loop of Henle.
The famous waterproof section.
Yes, and that is absolutely critical. The thick ascending limb is impermeable to water. It cannot let water pass. But at the same time, it actively pumps out sodium, potassium, and chloride into the interstitium, the surrounding kidney tissue.
So it's pumping salt out, but it's trapping water inside the tubule.
Precisely. This action does two things. It makes the fluid inside the tubule very dilute, and it makes the medulla, the deep tissue of the kidney, extremely salty or hypertonic.
And that's the countercurrent multiplier system I've read about.
That is the countercurrent multiplier. That medullary hypertonicity is the battery. It's the driving force that allows the kidney to pull water out and concentrate the urine later on. This site reabsorbs about 20 to 25% of the filtered sodium.
And unlike the proximal tubule, blocking this segment has a massive effect.
A huge effect. If you knock out the thick ascending limb, you achieve two things. One, you stop that 25% of sodium reabsorption right there. Two, and this is arguably more important, you destroy the medullary gradient. The battery dies.
So the kidney loses its ability to concentrate urine.
Completely. It can't pull water out of the collecting duct later, so you just get a torrent of dilute fluid leaving the body. That is why loop diuretics are called high-ceiling diuretics. There's very little compensation downstream.
Got it. Okay. Moving further down, the distal convoluted tubule, the DCT.
This is often called the diluting segment. It reabsorbs about 5 to 10% of the sodium load, and like the thick ascending limb, it's also impermeable to water. Diuretics that work here are effective, but they have a ceiling because the reabsorptive capacity is just lower than the loop.
And then finally we get to the collecting duct.
This is the fine tuner. It's all about precision here. It reabsorbs only about 1 to 2% of the sodium. This happens under the tight control of the hormone aldosterone. Water reabsorption here is controlled by antidiuretic hormone, or ADH. This is where the final composition of urine is decided.
So for the exam, when I move into classification, the key is to link the potency of the diuretic to its site of action on this line.
Correct. And that brings us perfectly to Part B classification. In your answer, you must always classify by both site of action and efficacy. If you just list drug names randomly, you lose critical marks for organization and, frankly, for understanding.
Okay, let's build that classification hierarchy then.
Yeah.
Category 1, the heavy hitters.
The high ceiling, or loop diuretics. They act on the thick ascending limb of the loop of Henle. The examples you must know are furosemide, bumetanide, and torsemide.
Okay. Category 2, the middleweights.
Medium efficacy diuretics. These act on the early distal tubule. These are your thiazides. The classic one is hydrochlorothiazide, but also remember chlorphalidone.
And the third category is usually grouped together as weak or adjunctive.
Right. It's a bit of a mixed bag. This includes the carbonic anhydrase inhibitors, which work way up in the proximal tubule.
The ones that get compensated for.
Exactly. Then you have the potassium-sparing diuretics, which work right at the end in the collecting duct. And finally, the osmotic diuretics, which are unique because they work more through physics than by blocking a specific receptor.
Okay, we have the skeleton. That feels like a solid foundation. Now let's add the muscle. Part C, individual diuretic classes. We have to start with the loop diuretics. Furosemide is. It's practically a food group in the ICU.
It is the single most important diuretic for the anesthesiologist to know inside and out. So let's break down the mechanism of action. You need to be very specific. Loop diuretics inhibit the NOTGRO-TCO cotransporter.
That's sodium potassium 2 chloride. And where exactly is this transporter located? On the cell surface.
It is on the luminal membrane of the thick ascending limb. That means it's on the side of the cell facing the urine. This is a critical point. The drug has to be secreted into the tubular fluid to work. It binds to the transporter from the inside of the tubule.
And by blocking this transporter, we wreck that medullary gradient we just talked about.
You've got it. You kill the battery. Now, clinically, let's talk about why we call them high ceiling.
Right. It means there's a big effect.
It means the dose-response curve is steep and long. If you give 20 milligrams and get a response, giving 40 milligrams will give you a bigger response. Giving 80 will give you even more. You can keep pushing the dose higher and higher to get more diuresis.
And that's useful in what situation?
It's crucial in renal failure. In patients with poor kidney function, the drug has trouble getting secreted into the tubule to its site of action, so you need to give much higher doses to get enough drug to the target. Thiazides don't have this property.
Let's talk about clinical uses. The absolute classic scenario is acute pulmonary edema. But there's a nuance here that examiners love to test you on.
This is Viva trap number 1. You have a patient who is drowning in their own fluid, gasping for breath, and acute pulmonary edema. You push a stat dose of IV furosemide. Within 5 to 10 minutes, they tell you they feel better, their breathing is easier.
But if you look at the urine bag,
It's empty. They haven't produced a single drop of extra urine yet, so the question from the examiner is, why are they better?
this one blew my mind when I first learned it. It's a vascular effect, isn't it? It has nothing to do with the kidney initially.
Exactly. Furosemide causes an immediate prostaglandin-mediated venodilation. It relaxes the large capacitance veins. This dramatically increases the storage capacity of the venous system, which in turn reduces venous return to the struggling heart.
So it drops the preload.
It drops the preload almost instantly. By offloading the heart, you reduce the back pressure on the lungs and the patient feels relief.
No.
The actual diuresis, the removal of fluid from the body, doesn't even start for another 20 to 30 minutes.
So in that acute setting, it's acting more like a dose of nitroglycerin or a molecular tourniquet.
That is the perfect analogy. It is a hemodynamic drug first and a diuretic second in that specific acute setting.
Okay. What about the direct anesthetic relevance? I mean, apart from managing fluid balance during a long surgery.
You absolutely need to know about the interaction with neuromuscular blockers.
Okay.
Loop diuretics are notorious for causing hypokalemia low potassium. Hypokalemia causes hyperpolarization of the muscle cell membrane, which makes it harder for the cell to depolarize.
And that means?
It means it potentiates or strengthens the effect of non-depolarizing muscle relaxants like vecuronium or rocuronium.
So the block from the muscle relaxant might last longer or be much deeper than you expected.
Correct, and it might be harder to reverse at the end of the case. It's a significant drug interaction. Also, never forget ototoxicity.
Hearing loss.
Yes, damage to the hair cells and the cochlea. This is dose-dependent and critically rate-dependent. If you push a high dose of Lasix too fast, especially in a patient who is also on other ototoxic drugs like aminoglycoside antibiotics, you risk causing permanent hearing loss.
So slow infusion for high doses. Got it. Okay, let's move on to the thiazides. Hydrochlorothiazide.
Right, mechanism of action. They inhibit the now close importer in the early distal convoluted tubule. Note the difference in the transporter. It's a symporter, not the co-transporter in the loop, and it only moves sodium and chloride.
And these are medium efficacy.
Yes, because the DCT only reabsorbs about 5 to 10% of the filtered sodium, so blocking it has a more limited or sealing effect. Once you've blocked all the transporters, giving more drug simply doesn't produce more diuresis.
And there's that crucial GFR limitation.
Yes. For the exam, you must state this. Thiazides become ineffective if the glomerular filtration rate, the GFR, drops below about 30 milliliters per minute.
So in a patient with significant renal failure, writing a prescription for a thiazide is essentially useless.
As a standalone diuretic, yes, it is. It won't work. Loops are your only option in that scenario.
There is a very, very important electrolyte distinction between loops and thiazides, specifically regarding calcium. This feels like a classic exam question.
Oh. It is. It's a favorite for multiple choice questions. The mnemonic to remember is, loops lose calcium. Loop diuretics increase calcium excretion in the urine. Thiazides do the exact opposite. They increase calcium reabsorption from the tubule back into the blood. They are calcium sparing.
So a clinical application would be a patient with recurrent calcium kidney stones.
You give them a thiazide, it reduces the amount of calcium in their urine, it treats the hypercalciuria, and helps prevent new stones from forming.
Now, let's tackle the paradox. Thiazides are used to treat nephrogenic diabetes insipidus. Diabetes insipidus causes massive polyuria, peeing out huge volumes. Why on earth would we give a diuretic to someone who is already peeing liters and liters a day?
It seems completely counterintuitive, doesn't it?
It really does.
Okay, so in nephrogenic diabetes insipidus, the collecting duct has stopped responding to ADH, so it just dumps huge volumes of dilute water. When you give a thiazide, you cause a state of mild but persistent volume depletion. You dry the patient out just a little bit.
Okay, I'm with you so far.
This mild hypovolemia is a powerful signal to the body. It lowers the GFR slightly, and it tells the proximal tubule to go into overdrive. The PT starts reabsorbing a much larger fraction of the filtered sodium in water to try and conserve volume.
So the PT goes into survival mode and sucks up everything it can.
Exactly. And because so much more fluid is reabsorbed proximally, much less fluid actually gets delivered to the defective distal nephron. Less delivery to the end of the line means less urine output overall.
So you're essentially tricking the proximal part of the kidney into compensating for the failure in the distal part.
You've nailed it. It's volume contraction leading to reduced distal delivery. It's a beautiful piece of physiology.
That is fascinating. Okay, let's move on to the potassium-sparing diuretics. These guys work at the very end of the line, in the late distal tubule and collecting duct.
And we have two distinct subclasses here. It's important to separate them. First, you have the aldosterone antagonists. The prototype is spironolactone. Second, you have the direct renal epithelial sodium channel inhibitors like amiloride and triamterene.
Let's focus on spironolactone. It's the one we see most often. Why does it take so long to start working?
It's all about its mechanism. Spironolactone is a competitive antagonist at the intracellular aldosterone receptor. This is not a cell surface receptor. The drug has to enter the cell, bind to the receptor, and then that whole complex has to go to the nucleus and alter protein synthesis.
So it's working on a genetic level.
It is. It's a genomic effect. It stops the cell from making new sodium channels and new sodium-potassium pumps. This process of stopping protein production and waiting for the old pumps to degrade takes hours to days to have a clinical effect.
So it's absolutely not an emergency drug for acute hyperkalemia or anything like that.
No, not at all. We use it for chronic management. It has a crucial role in improving survival and heart failure, not because of its diuretic effect, but because it prevents aldosterone-mediated cardiac remodeling and fibrosis.
Right, and it's also the drug of choice for liver failure.
For ascites and liver cirrhosis, yes, because those patients have a massive secondary hyperaldosteronism driving their fluid retention, and spironolactone directly targets that pathophysiology.
And the main anesthetic concern with this whole class is pretty obvious from the name.
Hyperkalemia. And this is a serious concern. If your patient is on spironolactone and they have even mild renal dysfunction, and then you give them succinylcholine for a rapid sequence induction.
Succinylcholine also raises potassium.
By about 0.5 milliequivalents per liter. You could easily push their potassium into a dangerously high range, risking arrhythmias or even cardiac arrest.
Okay, next up, osmotic diuretics. Mannitol. This is the neuroanesthetist's best friend.
Mannitol is completely unique. It is, for all intents and purposes, pharmacologically inert. It's just a large sugar molecule. It gets freely filtered by the glomerulus, but crucially, it cannot be reabsorbed by the tubule. So it gets trapped in the tubular fluid.
And because it's trapped in there, it exerts an osmotic pressure.
That's it. It acts like a sponge. It holds water in the tubule by simple osmosis, preventing it from being reabsorbed. We call this water drag. It works primarily in the parts of the nephron that are most permeable to water, which are the proximal tubule and the thin descending limb of the loop of Henle.
We use it to lower intracranial pressure, ICP, and intraocular pressure, IOP. But how does it actually shrink the brain? Is it just the diuretic effect?
No, the brain effect happens much faster, and it works on the blood first. When you infuse mannitol intravenously, it temporarily stays in the vascular space and makes the blood hypertonic. It increases the plasma osmolarity.
So the blood becomes saltier than the brain tissue.
Exactly. And this osmotic gradient pulls water out of the brain cells, across the intact blood-brain barrier, and into the blood vessels. The brain literally shrinks.
It dehydrates the brain.
It does. But here is the critical Viva trap. Because it pulls all this water from the intracellular space into the blood vessels, it initially causes an acute plasma volume expansion.
So it actually increases the blood volume for a short time.
Significantly, for about 30 to 60 minutes. Now imagine you have a patient with borderline congestive heart failure and a brain tumor. You give them a big dose of mannitol to shrink the tumor before surgery. That acute volume expansion can be the final straw that tips them over into florid pulmonary edema.
So congestive heart failure is a major contraindication for mannitol.
An absolute contraindication. That is a critical safety check you must mention in your exam.
Got it. And finally, the last class, the carbonic anhydrase inhibitors. Acetazolamide.
These are the ones that work way up in the proximal tubule. They inhibit the enzyme carbonic anhydrase. Without this enzyme, the tubule cannot reabsorb bicarbonate, the HCOO.
So you just pee out all your bicarbonate.
You do. And since bicarbonate is the body's main base, losing it makes the blood acidic and consequently makes the urine alkaline. It causes a very specific type of acidosis. A hyperchloremic metabolic acidosis.
We don't really use it for diuresis much anymore because, as we said, it's just too weak, right?
Correct. The distal nephron just compensates too well, but it has niche uses. In the ICU, we use it to treat severe metabolic alkalosis. If a patient has been over-diuresed with loop diuretics and their blood pH is dangerously high, acetazolamide can help correct that.
And altitude sickness.
And altitude sickness. The mild metabolic acidosis it causes is a potent stimulus for the respiratory drive, which helps you acclimatize faster.
Okay. We've dissected all the classes. This brings us to the really crucial part, Part D, clinical and anesthetic implications. This is where we show the examiner that we're not just pharmacologists, we're practicing clinicians.
This section is absolutely vital. This is what separates a pass from a distinction. Let's start with the most important topic, electrolyte disturbances. This is very high yield. You will see this in the exam, and you will see it every single day in the OR.
Hypokalemia has to be the big one.
It's the most common and arguably the most dangerous. It's caused by both loops and thiazides. The mechanism is that the increased sodium delivery to the collecting duct drives the secretion of potassium into the urine.
And clinically, why do we care so much?
Two main reasons for us. One, it predisposes the heart to arrhythmias, especially if the patient is on digoxin. Two, as we've already mentioned, it potentiates non-depolarizing muscle relaxants.
Then there is hyponatremia, low sodium.
This is actually more common and often more severe with thiazides than with loops. It's a bit complex, but essentially, loops inhibit the concentrating ability of the kidney, so you tend to lose salt and water in equal measure. Thiazides, on the other hand, impair the diluting segment without affecting the concentrating ability. This can lead to a dangerous retention of water relative to salt.
Okay, and we need to mention the acid-based disturbances.
Absolutely. Loops and thiazides cause metabolic alkalosis. This is sometimes called a contraction alkalosis. You lose volume, you lose chloride, and the kidney desperately holds on to bicarbonate to compensate.
And the others cause acidosis.
Correct. Acetazolamide and the potassium-sparing diuretics both cause a metabolic acidosis.
Okay, let's talk about practical management in the ICU and OR. The patient is on the list for surgery. They take a diuretic every morning. What do we do about the morning dose?
This is a common debate, but the general consensus now is leaning heavily towards withholding the morning dose for elective surgery.
And the reasoning behind that is?
The induction of anesthesia is a potent vasodilator. Propofol, sevoflurane, they all drop systemic vascular resistance. If a patient is already volume depleted from a morning dose of furosemide, their blood pressure can absolutely crash on induction. You're setting yourself up for severe hypotension.
So it's better to start with them a little bit full than a little bit empty.
Exactly. The exception might be a patient with very severe heart failure, where missing even one dose could tip them into pulmonary edema. In that case, it's a careful risk-benefit discussion. But for most, the rule is hold the dose, check their electrolytes pre-op, and carefully assess their volume status.
What about intraoperative oliguria? We've all been in that situation. 3 hours into a major abdominal case, the urine output drops below 0.5 milliliters per kilo per hour. The surgeon looks over the drapes and says, "Can you give some Lasix?"
And your job as the vigilant anesthesiologist is to say, not yet.
Why not?
Because giving a diuretic to a hypovolemic patient is one of the worst things you can do. You're just forcing the kidney to make urine when it's trying to conserve every last drop of fluid to maintain perfusion. It dramatically increases the risk of inducing an acute kidney injury.
So what's the correct algorithm?
First, you assess volume, always. Use your dynamic parameters if you have them. Pulse pressure variation, stroke volume variation, or just give a sensible fluid challenge of 250 mils of crystalloid and see what happens to the blood pressure.
And only if you're sure they're not dry.
Only if you are convinced the patient is euvolemic or even hypervolemic and is still not producing urine, should you then consider a small dose of a diuretic. The mantra is, do not whip a tired horse. Resuscitate first, diuretic second.
I love that phrase, do not whip a tired horse. Okay, looking at special situations, what is sequential nephron blockade? It sounds intense.
It is intense. This is a strategy we use for diuretic resistance, usually in the ICU for patients with decompensated heart failure. Sometimes, after chronic use of a loop diuretic, the kidney adapts. The distal tubule undergoes hypertrophy, it actually gets bigger and stronger, and it starts reabsorbing all the extra sodium that the loop diuretic is blocking.
The kidney learns to fight back.
It does. It's a very clever organ.
Right.
So to overcome this, you block 2 different sites at once. You give a powerful loop diuretic and a thiazide-like diuretic, such as metolazone. You block the loop, and you block the now hypertrophied distal tubule. It's a synergistic 1-2 punch.
And the result?
It's a massive, often torrential diuresis. But it is extremely risky. It can lead to rapid, profound electrolyte loss and hemodynamic collapse. You have to monitor these patients almost minute by minute.
Okay, let's quickly recap the key adverse effects you need to list in an exam answer.
Okay, list them out. 1. Dehydration and hypovolemia, leading to prerenal azotemia. 2. Electrolyte imbalance, hypokalemia, hyponatremia, hypomagnesemia with loops and thiazides. 3. Ototoxicity specific to loop diuretics. 4. Metabolic side effects. Thiazides can cause hyperglycemia by inhibiting insulin release, and both loops and thiazides can cause hyperuricemia and precipitate gout.
And some lipid changes too, right?
Yes, mild increases in LDL and triglycerides, usually with long-term thiazide use.
Okay, we are nearing the home stretch, part 13. Common exam questions and Viva traps. We've hit on a few already, but let's consolidate them into a rapid-fire round.
Good idea. Trap number 1. Why does 5-E furosemide provide immediate relief in pulmonary edema?
Answer. Immediate venodilation reduces preload. The diuresis comes later.
Perfect. Trap number 2. Where do osmotic diuretics like mannitol exert their primary effect in the nephron?
Answer. The sites most permeable to water, which are the proximal tubule and the thin descending loop of Henle.
Excellent. Trap number 3. Explain the paradoxical effect of thiazides in diabetes insipidus.
Answer. They cause mild volume contraction, which enhances proximal tubule reabsorption, leading to less fluid delivery to the distal nephron.
You're on a roll. Last one. Trap number 4. Why is acetazolamide a weak diuretic?
Answer. Because its action in the proximal tubule is largely overcome by compensatory sodium reabsorption in the more distal parts of the nephron, especially the loop of Henle.
Distinction level answers? All of them.
Okay, and finally, part 14. Presentation. This is about scoring the points. How do I actually write this 20-mark answer to make the examiner's job easy?
Visuals. Visuals are non-negotiable. You must draw a simple, clear diagram of the nephron. Don't just scratch out a squiggly line. Draw the glomerulus, the PT, the loop, the DCT, the collecting duct. Then clearly label the 4 main sites of diuretic action site Li, 2, 3, and 4, and write the name of the drug class that works there.
And maybe the transporter they block.
Even better, show that NAK2Cl transporter in the loop. That shows deep understanding. Second, use a comparison table. Examiners love tables.
What should I compare?
The big 3. Loop versus thiazide versus potassium sparing. Make columns for site of action, mechanism, efficacy or potency, effect on calcium handling, and the main side effects.
A good table probably saves you from writing a full page of dense text, and the examiner can scan it and tick off the points in seconds.
Exactly. You are making it easy for them to give you the marks you deserve. Structure and clarity are everything.
This has been an incredibly thorough deep dive. Let's wrap this up with a summary and exam conclusion. The 15-point recap for everyone to listen to on the way to the exam hall.
All right, deep breath. Here we go. 1. Diuretics increase urine output primarily by inhibiting sodium reabsorption, which is natriuresis. 2. Potency depends on the site of action. The loop of Henle is the most powerful site. 3. Proximal tubule diuretics like acetazolamide are weak due to powerful distal compensation. 4. Loop diuretics like furosemide inhibit the NACO2 cotransporter in the thick ascending limb. 5. They are high ceiling and remain effective even in severe renal failure. 6. Key uses. Acute pulmonary edema, where their initial effect is venodilation plus heart failure and hypercalcemia. 6. Key uses. 7. Thiazides inhibit the NACO symporter in the distal convoluted tubule. 6. Key uses. 8. They are medium efficacy or calcium sparing and find ineffective if the GFR is less than 30. 6. Key uses. 9. Potassium sparing diuretics like spironolactone work in the collecting duct, primarily used to counteract potassium loss and for their antifibrotic effects in heart failure. 6. Key uses. 10. Osmotic diuretics like mannitol work via osmotic drag to reduce ICP and IOP, but are contraindicated in congestive heart failure due to initial plasma expansion. 11. Remember the key electrolyte issues. Loops and thiazides cause hypokalemia, which increases arrhythmia risk and potentiates muscle relaxants. 12. A key distinction. Loops lose calcium, thiazides save calcium. 13. Major anesthetic implication. Hold the morning dose to prevent severe hypotension on induction. 14. For intraoperative oliguria, assess and correct volume status first. Do not blindly give diuretics. 14. For intraoperative oliguria. 15. And finally, sequential nephron blockade is a high-risk, high-reward strategy for severe diuretic resistance.
That is the gold standard summary right there. Incredibly concise.
If you can articulate those 15 points clearly, and you draw that nephron diagram in the comparison table, you aren't just passing, you are aiming for the top of the batch.
Before we sign off, is there one final thought, a slightly more advanced concept to leave us with?
I want to leave you with the concept of the diuretic breaking phenomenon. We touched on resistance, but this is the physiology behind it. When you give a diuretic, the body doesn't just lie down and accept it. It senses the volume loss. It immediately activates the sympathetic nervous system and the renin-angiotensin-aldosterone system. It actively upregulates the sodium transporters in the parts of the nephron you aren't blocking. This is why the effect of a diuretic tends to wane over time, and why the first dose is almost always the most effective. The kidney is smart. As an anesthesiologist, your job is to be smarter.
The kidney fights back. A perfect final thought. Listeners, grab a piece of paper, draw that nephron now while it's all fresh in your mind.
Good luck with the exam. Remember, precision is key.